And we've been having a series of early career researcher presentations, and but this talk seemed of broader interest, and so we opened it up to the entire campus, and very excited to see how many people showed interest in the topic. So I'm very excited to listen to the seminar today. So TV.
Yes. So hi all, and this is really exciting, and thank you for joining us. So a few things I wanted to mention, because there are lots of people who have registered for this presentation today. So let's follow few rules. So please mute yourself when your presenter is speaking. Type your questions in the chat box. I will take those one by one at the end of the presentation. If time permits, we will have open mic at the end of the session. At that time, please raise your hand if you want to speak or ask questions. So with that, I'm thankful to our today's speaker, Dr. Quanquan Gu, for accepting our request to present his research work on the current and the most prevalent issue in the world, COVID-19. The topic of this presentation is Epidemic Model Guided Machine Learning for COVID-19 Forecast. Dr. Gu is an assistant professor at UCLA Computer Science Department. His current research is in the area of artificial intelligence and machine learning, which is a focus on developing and analyzing non-convex optimization algorithms for machine learning and building the theoretical foundations of deep learning. He received his Ph.D. degree in computer science from University of Illinois, Urbana-Champaign. His achievements include Yahoo Academic Career Enhancement Award, NSF CAREER Award, Simon's Berkeley Research Fellowship, Adobe Data Science Research Award, Salesforce Deep Learning Research Award, and Amazon Web Services Machine Learning Research Award. So without much delay between you and Dr. Gu, I will ask him to come online. Dr. Gu.
Okay, yeah, thank you for the introduction, and thank you for inviting me to give a presentation in this weekly seminar. I'm so excited to share with you guys about my recent project using machine learning for COVID-19 modeling and forecast. So the title of my presentation is Epidemic Model Guided Machine Learning for COVID-19 Forecast. So the keyword is epidemic model and machine learning. So through this talk, I will show you how to integrate these two separate components. One is from epidemiology, the other is from computer science and AI. So I will start with the background with about COVID-19. So COVID-19 is an infectious disease caused by the recently found virus known as SARS-CoV-2 or coronavirus. And because of COVID-19, as of June 1st, just Monday this week, there are already more than 6 million people in the world diagnosed as COVID-19. And out of these 6 million people, there are about 377,000 people died from COVID-19. So if you calculate the case fatality rate in the world, it's about 5.93%, actually, which is a really high rate. But considering that there are many under-tested cases or unreported cases, so the real fatality rate actually is lower than this one, but it's still a big number. And if you look at the number of confirmed cases and the deaths in the United States, you can see that actually we have a lot of people in the United States confirmed as COVID-19. So it's about 1.85 million people in the United States diagnosed as COVID-19. And more than 100,000 people died from COVID-19. And the case of fatality rate is about 5.75 percent in United States. Okay, this is slightly lower than the case fatality rate in the world, but it's still very close. And California, although it's not the state that has been hit by COVID-19 most severely, but it's definitely among the top of those states which have the most number of confirmed cases across the country. So you can see that there are more than 100,000 people in California diagnosed as COVID-19, and more than 4,000 people died in California because of this. And we are in Los Angeles, so you probably are more interested in the number in Los Angeles. So in Los Angeles, there are about 50,000 confirmed cases, which is almost half of the confirmed cases in California. So LA is indeed a hotspot of COVID-19 in California. And even if you look at the number of deaths, it's more than 2,000, which is also about half or even more than half of the deaths in California. So because of these numbers, it's very urgent to do something to control and mitigate the spread of COVID-19, and to make sure we will our life and work will get back to normal as soon as possible. And in order to respond to COVID-19, the most important things are, of course, the public health interventions. These include the travel restriction, social distancing, stay at home, contact tracing, quarantine, isolation, and of course, wearing masks and face covers in the public space. So we have been doing this in the past several months, and I think we are doing a great job. And if you look at the curves, I'm going to show you in later slide. Actually, I think we are in a relatively good situation, and I hope this pandemic will be gone just in a few months. So as an AI and machine learning researcher, when this pandemic started about 3 months ago, so I asked myself what I can do to combat or to help combat COVID-19. So I came up with a list of things that I think AI and machine learning can help for battle COVID-19. This include modeling and forecast. So this is something I'm going to focus on in today's presentation. And the other things that AI and machine learning can do to help combat COVID-19 is, for example, design sampling and testing strategies. If due to the testing capacity, we are not able to test every single person in this country, we have to do some kind of sampling. And the uniform sampling is, of course, is not the most effective sampling strategy because there are hotspot or cold spots in different communities or in different regions of the county. So how to come up with a adaptive sampling strategy will be crucial to get a good understanding about the spread as well as the prevalence of this disease in the community. And the other thing we can do is drug design and repurposing. This involves using machine learning models to compare the similarity or dissimilarity between drugs. And we may be able to identify some existing drugs that can be effective to cure COVID-19. And the last thing on this list is chest X-ray image diagnosis or CT image diagnosis. So this is just a partial list of things that I think AI and machine learning can do to help combat COVID-19. There are many other things which I didn't show here, but I believe AI and machine learning can also help. So in today's presentation, I'm going to focus on the modeling and the forecast part. And regarding that, we launched this project called Using Machine Learning to Combat COVID-19 about 2 months ago on March 28th, 2020. So we have a project website. The URL is shown this slide. If you are interested, you can go to the project website just to just randomly, you can just try different menus and see different things we have done on this project. And the central goal in this project is to forecast the number of confirmed cases as well as the number of deaths in at different levels, including the national level, the county level, the state level. So our objectives include the following things. The first thing is forecast the number of confirmed cases and the deaths of COVID-19. The second objective is to estimate the peak date in different states in the entire country or in different county. And we will also estimate the basic and the effective reproduction number for different states and counties. And lastly, we recently added some estimation of the COVID-19 preference, which I will talk about it in the end. So I will start with the forecast about the number of confirmed cases as well as deaths. Okay, so here's the basic idea about the forecast. We can get the daily reported confirmed cases as well as deaths from some, for example, NY Times or Johns Hopkins University data repository. So therefore, we can plot the number of cumulative confirmed cases as well as number of cumulative deaths. So in this figure, you can see that those solid curves corresponding to the reported cases. And based on the reported cases, we would like to project how many number of confirmed cases or how many number of deaths will be in a week or in a month. So the dashed line in this figure is the projected number of confirmed cases and deaths. And in addition to this point estimation, we also provide confidence interval to assess the uncertainty of our projection. So here we show the 95% confidence interval, which include the upper and the lower bound of the projection for both confirmed cases as well as deaths. And there are many things or many different methodologies we can use to estimate the confirmed cases. For example, the HME in UW, University of Washington, they use the curve fitting to forecast the number of confirmed cases and deaths, which is a very widely recognized model in the public. Okay, but in this project, instead of using curve fitting, actually I take a different approach. Actually, it's more standard approach, just to use epidemic models to model the underlying dynamics of the disease, how the disease spread among the community. And based on this epidemic model, I will use machine learning algorithm to learn the parameters of the epidemic model. And with that, I can predict or project the number of confirmed cases and deaths for future date. There are two classical epidemic models. The first one is called the ACE-IR model. The ACE represents susceptible, I is infectious, and R is removed or recovered. So this model divides the entire population into three groups. The first group is called the susceptible group, which contains individuals that are under the risk of being affected by the disease. The second group is called the infectious, which contains those individuals who have already been exposed and affected by the disease. And the last one is called removed. So removed group contains individuals who both recovered from the disease or died from the disease. And both of them, we call it removed cases. And there's a dashed line from the infectious group to the susceptible group, which means the individuals in the infectious group can affect the individuals in the susceptible group. Okay. So this model can be described by a system of differential equations, which is shown on the right side of this figure. So there are 3 ODEs. Each of them correspond to a dynamic within each of the groups. And you can see that this ODE is governed by 2 parameters. One is called the beta parameter, the contact rate. The other is called gamma parameter, which is the transmission rate. And because of for many diseases, there's an incubation error, and because of that, people proposed a modification of SIR model, which is called the SER model. So in SER model, there's an additional group called the exposed group. So the individuals in the susceptible group, before they transfer into the infectious group, they will first go into the exposed group. So the individuals in the exposed groups are those people who are exposed to the virus, but haven't developed any symptom or not really infected by the disease. And for some of the individuals in the group, they will later develop symptoms and be considered as infectious individual, so that they will be moved into the infectious group. And because of that, there's additional parameter sigma, okay, which is the fraction of people in exposed group that will later get affected. And only the individuals in the infectious group will affect the individuals in the susceptible group. So therefore, there's a dashed line from the infectious group to the susceptible group. Okay. So this is the basic idea of SIR and the SER model. However, there are 2 limitations of these 2 classical epidemic models. The first limitation is they do not take into account the untested or unreported cases. So this is a very common cases in COVID-19 due to the testing capacity and also due to the asymptomatic individuals. So there are many people who have already exposed to a virus or even got infected, but because of no testing, you don't know they are actually positive, and they are not reported to the public data repository. Another limitation of SIR and SER model is they do not take into account the asymptomatic individuals. So just like I said before, there are many people who actually are positive in COVID-19, but because they don't have a symptom, so that's why you don't know, and they for example contact with other people and then get more people affected, right? But this is not well modeled in either SIR or SER model. Okay. And in order to overcome the limitations of the classical epidemic models, we propose a new model called the SUER model. So here U represent unreported cases. So we add an additional group into the mathematical model, which is the purple one called the unreported group. So for those individuals in the exposed group, a mu fraction of them will go into the infectious group, and mu is called the discovery rate of infected cases. And the other 1 minus mu fraction of the individual in the exposed group will go into the unreported group. And this mechanism is used to model the untested and unreported cases for COVID-19. And the other key difference between our model and the SER model is, as you can see, in SER model, the individuals in the exposed group will not affect the individuals in the susceptible group. But in our model, the individuals in the exposed group will also affect the individuals in the susceptible group. So this is the second key difference between our model and the SER model. Okay, so putting these two additional pieces together and integrating them with the original SER model, we are able to come up with a new systems of the ordinary differential equation, which is shown on the right side of this figure. So there are 4 underlying dynamics: ST, ET, IT, and RT. And each of the ODE can be written according to the structure of the mathematical model shown on the left-hand side. Okay, so I'm not gonna to derive this ODE to show you how to derive it, because you can do it as an exercise. It's not that difficult. So given the epidemic model, then we will use machine learning algorithms to fit a model to the data. So basically, we want to estimate the parameters of the epidemic model based on the reported data we get from the public data repository. So the machine learning pipeline is as follows. So it takes the several things as input, which includes the initial susceptible population and the initial exposed population, as well as the daily reported active cases and the daily reported deaths and the recovered cases. And then it will use some loss function to define the goodness fit of the model to the input data. And by minimizing that loss, we will be able to get the parameters of the epidemic model, which are beta, sigma, mu, and gamma. Okay. So after we learn the model, we will use the model for prediction to predict the future active cases, as well as the future deaths and recovered cases. Okay, so in specific, we define the following loss function, which is the square of the log transformation of the confirmed cases as well as the recovered cases, because we can get access to the daily reported number for this several different cases. And the key idea of the training process actually is twofold. The first step is doing forward propagation. This corresponds to given the initial parameter and also the initial estimate of S0, E0, I0, R0. We are using some ODE solver to construct the estimated active cases as well as estimated removed cases from time 1 to time t. And then in the backward propagation process, we are going to minimize the loss function, which is shown in this equation, using some optimization algorithms. So the optimization problem actually is non-convex. So you can use some, for example, off-the-shelf solver like ALBFGS, or you can use stochastic gradient descent. Okay, so you may end up with different minimizer to these minimization problems by using different initialization or by using different optimization algorithms. So we need to do some kind of a model selection or hyperparameter tuning to get a reliable solution to this minimization problem. Okay, so now I want to talk about how to model social distancing in our model. Right? So the key idea is, key observation is only a fraction of population is susceptible to be infected. Okay, not all the population, because many people, they stay at home, they don't interact with other people. So in that case, the chance of being effective will be much lower than the people, for example, some essential workers, they need to commute to work every day. And this actually will increase their chance of being affected by the COVID-19 or coronavirus. So in order to model this social distancing measure, so actually we introduce a fraction parameter called that. We assume that after the, for example, the implementation of the social distancing order or social distancing policies, there's only delta fraction of a population that will be affected, that will be modeled during this, within this epidemic model. And this delta actually is a hyperparameter we need to tune when we fit the model to the data. And the next question is, as you remember, there's a removed group, but for removed group, it contains both recovered cases and deaths. And in order to project the number of deaths, we need to somehow separate the individuals in this group into two subgroups. The one subgroup corresponds to the individuals who got recovered from the disease, and the other subgroup are individuals who died from the disease. And this ratio actually is really important. And in order to get a good estimate about the ratio of the daily increased deaths versus the daily increased recovered cases, actually we introduce a function which is an exponential function, a times exponential minus t, b times t. So there are two parameters, a and b, and we need to estimate these two parameters based on the historic data to estimate the ratio of deaths versus recovered cases. And by using this function, and also by using the data in 4 different countries, including US, China, France, and Italy, we are able to estimate the parameters of A and B in this ratio function. And you can see that the performance of this exponential function actually looks very good. In all these 4 countries, by fitting the function to the historical data, we'll be able to project the number of removed cases in a very accurate way. So the solid blue curve is the ground truth data, the reported number of recovered and deaths. And the dashed red line is the estimated. So these two curves are pretty much aligned with each other. So that means this function is a good function to describe the ratio of deaths versus removed cases. And the next thing we need to do is to construct the confidence interval. So as I mentioned before, we not only provide the point estimate, we also provide the confidence interval. So therefore, we need to figure out how to construct the confidence interval. So I've seen people complain about some kind of projection without any confidence interval, because they think without a confidence interval, the projection is not very scientific. Right? So this is really crucial in order to deliver some reliable projections to the public. We use the likelihood ratio test to construct the confidence interval of the parameter of our model. So suppose theta naught is the length parameter, and we just construct the test statistics as the difference of the loss function at theta naught minus the loss function at theta height. And we can show that this test statistics actually follow a degree 4 chi-square distribution. And based on this fact, we can compute the 1 minus alpha quantile of the chi-square distribution to determine the theta height, which is sitting on the boundary of the confidence ball. And note that this is just the confidence interval for the model parameter. So we still need to convert this parameter confidence interval into the predicted confidence interval, because later we want to provide the confidence interval for the number of projected deaths and the number of projected confirmed cases. So for more details about how to construct the confidence interval, you can refer to the following paper as well as our manuscript on MetaArchive. Okay, so we actually are collaborating with RecLab at UMass, which they built a so-called COVID-19 forecast hub. And within that hub, there are now, I think, as of today, about 20 teams across the country, as well as from UK or some other countries. So they put together a very huge team of people who are doing COVID-19 forecast. And we are one of those teams. And we provide our national and state life or death forecast to them on a weekly basis. And they are gonna do in some kind of ensemble to integrate the forecast from different teams to provide a more reliable forecast for the national and state level number of deaths. And this data actually is later used by CDC for the national level and also state level death forecast. So as you can see, we are one of the about like 15 models used by CDC. And all these 15 models actually are models from the COVID-19 forecast hub. And here, let me show you some comparison between our forecast and the other models used by CDC. Okay, so these include the models, the very famous model called the IHME, which is the UW model, as well as other models developed by MIT, UT, Austin, and some other national labs. And you can see that for the week of May 5th, okay, it's about like 3 weeks ago. Because these data are already observed, the number of confirmed cases or number of deaths, they are observed data. So we can calculate the difference between the projection and the ground truth, the reported number. And we use border rank aggregation method to rank the daily ranking, to combine the daily ranking of different models in terms of the projection. And our model actually is ranked second for the death projection in that particular week. And for more comparisons, you can find it on our website. So we basically update this model on a weekly basis. So you can tell which model provides the most accurate projection. And also you can see the performance of our model. And in just the following week, in the week of May 12th, our model actually was ranked number 1. Okay. And the last week, I think our model was ranked number 3. And we are also collaborating with another team at UCLA. So they launched the so-called Stop COVID-19 Together project about also 2 months ago. And they are doing actually survey. So they ask people to fill out some survey to show, for example, whether they have some symptom or whether they go to some grocery store and whether there's a diagnosis cases in that grocery store, and so on and so forth. And they on their website, they also provide the county level forecast, and they are using our forecast for the top counties in United States, which have more than 1,000 confirmed cases. All right, so in the remaining of my talk, I will move on to the several important and also interesting things, including peak date prediction and the prevalence prediction. So regarding peak date prediction, actually we predict the number of active cases, because the number of active cases will most affect the use of the medical resources. And in our model, the number of active cases actually is the number of individuals within the infectious group. So after we train our model, actually we can immediately estimate this number. And based on this number, we can just plot the number of active cases for the next, for example, couple of months. And in that way, we will be able to figure out what's the peak date for different regions. So this is the peak date we predicted for in California. So we think the peak date in California will arrive around June 25th, just in about 20 days. And we also provide the confidence interval for the active cases. So there's a range about the peak date. And here we show the estimated peak date for the United States as well as other states in the US. And you can see that the peak date in US is May 31st. Actually, it's just a few days ago. And you can see that New York actually already passed their peak date. But in California, as I just mentioned, we will reach a peak date in about 3 weeks from today. And another important thing is the so-called R0. You probably see R0 in a lot of news articles or some other like media resources. So what is R0? R0 is called the basic reproduction number, which is the expected number of cases directly generated by one case at the beginning of the outbreak. Okay, so not means at the beginning of the outbreak. So for Ebola virus, actually, the R0 is about 2. And for SARS, R0 actually is equal to 4. And for our model, we are able to estimate the R0 as long as we can estimate the S0, E0, I0, and R0. For standard epidemic model like SIR and also SEIR, actually it's very easy to calculate the R0. You can find those calculations on Wikipedia or in the original papers. But since our model is a modified SEIR model, so it's not immediately clear how to calculate the basic reproduction number R0. So we are following the so-called next generation matrix calculation method to calculate the R0. So basically we construct a vector, which is a vector of the parameters of the model. And then we calculate the Jacobian of the this vector, because this can be seen a function of the model parameter. So we can calculate the Jacobian matrix of these vector valued functions with respect to the to ET and RT. And given the Jacobian matrix, actually we can calculate the next generation matrix, which is F times V in first. Okay, so here F and V are the partial Jacobian matrix with respect to ET and RT. Okay, so in that way, the basic reproduction number actually is defined as the minimum eigenvalue of the next generation matrix. And by doing some kind of calculation, we can show that the basic reproduction number R0 equal to beta divided by sigma plus beta mu divided by gamma. So beta mu, sigma, gamma actually are the parameters of a model. Therefore, as long as we have an estimate for these parameters, we are able to estimate I0. Okay. So this table summarizes the estimated R0 for different states and also for US. You can see that R0 for US is about 2.5. Okay, it's actually not as high as the R0 of SARS. But in, for example, New York or New Jersey, the R0 actually is pretty high. The highest R0 we observe is in the New Jersey state. And also in Massachusetts, actually the R0 is also above 4. In California, actually the R0 is just 2.2. Actually, it's smaller than the R0 in the entire United States. Okay. And based on R0, we can calculate the effective reproduction number, which is called RT. Okay, so when t equal to 0, you get R0. But since this is a dynamic process. So we can actually track the reproduction number with respect to time, which is called the effective reproduction number. And by doing some kind of calculation, we can show that RT actually equal to R0 times ST divided by S0. And since we are able to estimate the entire sequence of ST, then we are able to estimate the effective reproduction number RT. So when RT is greater than 1, actually, the number of effective individual will increase. And when RT is less than 1, then it starts to decrease. So this actually is also correlated to the active cases, correlated to the peak date projection. So let me give you 2 examples. In California, the curve of the effective reproduction number looks like this. So as of May 28th, the RT actually is still above 1. Okay, but as of today, you can see that today is June 5th. The RT is just slightly higher than 1, but it's already very, very close to 1. So this is very good news. And that's also the reason why in about 3 weeks, we project that we will arrive at the peak date in California. And in New York State, as of May 28th, the RT is already lower than 1. And as of today, June 5th, the RT actually is less than 0.5. So that's why you can see that the number of actually confirmed cases and deaths in New York State declines a lot in the past 2 weeks. This is pretty consistent with our estimation of the effective reproduction number in New York State. And lastly, we can estimate the prevalence. So prevalence is the proportion of a population who has a specific characteristics in a given time period. Okay, so in other words, we want to estimate the ratio of people who have the COVID-19 disease. So this included the asymptomatic individuals. Okay, and the most effective way to estimate COVID-19 prevalence actually is using antibody test, right? But currently, even the testing capacities keep improving. But as I mentioned before, it's still impossible to do antibody test for every single person. But there do exist some very comprehensive antibody tests in New York State. For example, they found that for general population, the prevalence in New York City is about 20%. Actually, this is a number a few weeks ago. And in our model, actually, we can estimate the prevalence by using this formula. Basically, just the sum of ET, IT, RT, and UT divided by the number of populations. And based on that, we are able to estimate the prevalence in the United States. So this is the estimate we did in May 23rd. So the prevalence in New York City is about 20%. Actually, this is pretty consistent with the prevalence estimate from antibody test. And there's a study by people at USC. So they basically estimate the prevalence in Los Angeles County based on the data on April 10 and 11. So their estimate is the prevalence in Los Angeles is about 4%. This is as of April 10, okay? And based on our model, actually, we can also estimate the prevalence in on April 11, which is about 1.8%, which is lower than their estimate of the prevalence. But on May 23, the prevalence in LA actually is increased to 9%. Okay. So this is just some estimate. You cannot interpret it as a very, for example, very like solid estimation. Is not a very solid estimation, but at least it can provide some evidence or some kind of information about the prevalence, in addition to the prevalence estimate from antibody test. Okay, so some people may ask me, can you model reopen? Because we are reopening, right? We are in stage 2 of reopening in California. So this is very important question to ask. And in order to model the reopening, actually we introduce another information flow, which is called the alpha T. So you can see that we just add another like in link to the susceptible group. So when we do reopen, so we will add more and more people into the susceptible group. And this is controlled by the parameter alpha T. And we can define this parameter as a step function if we think the reopening effect is like a step function. But we can also use more sophisticated functions inside of a step function to model the increase of the susceptible individuals in the susceptible group. So this is the idea how we are modeling the effect of reopen. All right. So with that, I would like to summarize my talk. So the high level ideas, I just show that by using the epidemic model as well as the machine learning, by putting them together, we can provide very accurate and reliable projections. And in addition to projection, we can also provide the peak date, the reproduction number, and the prevalence estimate, which can be used to better understand the severity of the epidemic outbreak. And finally, I just mentioned the ongoing research that we are using some kind of modified model to understand the effect of reopening. And we will, actually we are integrating this component into our current model. And we hope that can lead to even more accurate projection. And in the future, we will study the infection fatality rate as well as the discovery rate. And we will also try to provide a more comprehensive understanding of intervention. All right, so with that, I would like to thank you, my collaborators, and also thank all those healthcare workers who are working on the front lines of this COVID-19 battle. Thank you.
Thank you, Dr. Gu. There are many questions on the chat, so let me take one by one.
Okay.
Of those.
Thank you.
So from Parag, we are doing social distancing and quarantines, but then for the LA County, why the numbers are so high? Are we able to identify any patterns why some areas are more worse affected than others? Can some behavior be identified to further prevention?
Yes, yeah, that's a very good question. Yes, we can do that. Actually, in this talk, I mainly talk about the national level and also the county level, state level projection of the deaths and the confirmed cases. And actually, we are very, very interested in the county level modeling, including the Los Angeles County as well as the Santa Clara County, because actually we have been talking to someone in the Department of Public Health, the local Department of Public Health, and we want to provide a thorough analysis about the spread of the COVID-19 within the community. And what we are currently doing is we collect the data, which is called the mobility data. So there are some websites, including, for example, Apple and Google, they provide the mobility data. They make it public and it's free for research. And based on those mobility data, actually we can track the movement patterns or traffic patterns within the ALA county. So in different community or cities of ALA, actually the mobility data, the pattern are quite different. So some of the regions are more active than the others. And this is, we believe this is correlated to the spread as well as the outbreak of the COVID-19 disease. So we call it as a hotspot detection. So we are doing hotspot detection in Los Angeles by using the mobility data. So the result hasn't been put online yet, but I think this is something very to your question, and yeah, we are working on that, and hopefully we'll get it online in a week or 2 weeks. Yeah.
A follow-up question from Parag himself. How do we go improving efficiency with similar data sets available online?
The efficiency.
Efficiency with similar data sets. So how do we improve the efficiency with similar data sets available online?
Okay, so I guess the question may be about the comparison with other, because for all those models we compared in our study, for example, for all those models, they basically use the same source of data set, including the NYTime data repository and the Johns Hopkins data repository. Some of them using the COVID tracking, the data from the COVID tracking website. But the majority of the models we compared, actually, they are using the same source of data set. Regarding the model efficiency, actually, our model is very efficient because you can see that our model actually is like machine learning driven epidemic model or active model guided machine learning. We just use some off-the-shelf optimizers to minimize the loss function. So to give a rough idea, in order to train a model, we only need 5 seconds to train a model for each state. So that means we can train 100 or even 1,000 models a day. If we want to data the model when we get additional data information. Yeah.
The next question is from Davida. How do the recent public events protest impact the model, where people have more contact, or is there any impact?
Yeah, so I think, yeah, just like I said, in terms of the opening, I believe there's some impact. And in terms of, for example, the public event, there might also be some like impact, but this is something we will not observe it immediately, because for the disease there's like an incubation area and there's some development period. So the things, for example, or the event happening, for example, today, its consequence will be observed maybe in about, for example, 1 week to 2 weeks, because there's an incubation area. So I believe there's some impact about, because of these all different things you are talking about is about the mobility of the certain group of people, right? When people gather together, of course, the chance of being contacted by the people who have the disease will be substantially increased. But on the other hand, when people, for example, gathering, they do very good social distancing, or they wear the face covers. And in this sense, maybe the risk will be mitigated significantly. So I think that it's totally depends on whether they are doing good social distancing when they are doing gathering, and this is like a long-term impact, is not like a short-term impact. So so we will see how it will affect maybe in about 2 weeks.
Next question. The model doesn't seem to suggest any possible connection between unconfirmed infectious cases and confirmed infectious cases. Why would unreported cases not also drive new reported infectious cases?
Oh, I see. Yeah, that's a good question. Actually, there's indeed a connection, actually very strong connections. So as you can see, without this underreported data, okay, so then the transition of the individuals from the exposed group to the exposed group to the infected group will be, all the, for example, individuals in the exposed group will with certain transmission rate moved into the infectious group. And if we are not using the unreported group, we won't be able to provide very good projections about future deaths and future confirmed cases. Okay, so to put it in another way, okay, the unreported cases actually plays a central role in terms of the prediction. Although later when we do prediction, we only, for example, use the fraction of the removed individuals which correspond to the number of deaths. But the unreported cases is more like a hidden variable. Without this hidden variable, right? So when we do projection, of course, you don't use this hidden variable, the value of this hidden variable. But without this hidden variable, actually, the performance of the model, which is actually the performance of the standard epidemic model, will be much worse than the performance of our model. And if you look at those models I described in this table, not only our model, but also many other models, they consider the unreported cases, but they may doing it in a different way, or may not be as principled as our way of dealing the unreported cases. Yeah. But the unreported case actually is essential, and it's critical to be modeled in this epidemic model in order to get very good projection. Yeah.
So next question is, can you estimate how the relaxing of distancing restrictions across CA this month has affected your unsusceptible population model? In this same concept, can you model how different levels of decreasing social distancing will affect the daily death rate to depict the reopening of CA and potential pitfalls to educate the public on these dangers?
Yeah, that's a very good question. Yeah, we can actually model the effect or the influence of, for example, different level of like lifting the social distancing or lifting the shutdown or stay-at-home orders on the, for example, future daily deaths and the future, for example, daily reported confirmed cases. The how that actually is showing in this slide. Okay, because this is a model and we fit this model based on the data. But on the other hand, once we fit the model, actually we can do some kind of simulation. We can simulate the dynamic of, for example, ST, TIT, RT by slightly changing those model parameters. And in order to understand the impact of, for example, reopening on the, for example, on future confirmed cases and future deaths, we just need to, for example, slightly tune this parameter, which is alpha t, or even simpler, you can just tune this parameter, delta, right? Because this parameter actually is related to the level of social distancing. If we are doing very strict social distancing, then this delta will be very, very small, because only a very small fraction of population will be susceptible, right? But if we are doing relatively loose social distancing, then in the worst case, the delta can equal to 1. Right? So after you get the trained model, actually you can change this parameter, and but you still use the parameter as fixed, and you just change this parameter to that model simulate the for example, the evolution of the individuals in this 4 or 5 groups, and you can see the pattern, how the pattern changes. Okay, so this is exactly something our model can do.
Thank you, Dr. Gu. Next, do you still have time, because we are little above the time limit?
Yeah, I have time. Yeah,
okay.
It's up to you. Yeah, if people want to stay, then I'm more happy to answer questions.
Okay, thank you. So the next question is, have you modeled what will happen if the schools go back to in-person sessions?
Yeah. Actually, that's a very, very good question. Actually, I saw some like news articles in about daily, but you know, uh, uh, our model is more in the state or county level. It's not in the like university or campus level. So I'm not sure whether our model can be directly applied to model the, for example, what's going to happen if we, for example, reopen for example, the campus to resume in-person, for example, meeting or class. This is something I think is very, very important to study. But you know, our model actually relies on the training based on the reported data from NY Times and Johns Hopkins University, right? But we probably don't have enough data because even on campus, I don't think there are many confirmed cases at UCLA. So we don't have a good amount of data to build a model on the campus level. But what we can do is maybe we can borrow certain level of knowledge about the modeling, for example, in Los Angeles County, and apply it to the UCLA campus. That's a potential way to understand what will happen if a school go back to in-person section. But it is a very rough idea, and I don't have a very like concrete idea to do that. But yeah, I will think about it. That's a very good question, and I think this is very, very related to our study and research in the next few months. Yeah.
Next question is the parameters in the model are depended on contact rate, which actually change with time. For example, people didn't wear masks and keep social distance at the early stage of the pandemic. Mm-hmm. What's your opinion on the effect of this to your model?
Yeah, so in our current model, the contact rate actually is a constant. When we train the model, we get, for example, beta, which is the estimated contact rate. It is a constant. It is a constant over the time. It's not time varying. It's a great suggestion to make it a time variant, for example, parameters. But the thing here is even if you look at the individuals within the susceptible group, they are not like a homogeneous group of individuals, because think about the modeling, for example, Los Angeles County, we put all those, for example, individuals in different regions, in different cities, okay, into this group. But as I mentioned before, for example, the distribution of the susceptible individuals may actually are not uniform across the LA counties, right? There could be some regions which are at a higher risk, and the other regions is like a cold spot, right? So in order to do that, it's not only about time variant beta, it's also about the time variant subgroups within the susceptible group. So this is a very complicated modeling problem, and one can be, for example, improved or affected by the other. So, so back to our question, I think in order to provide some like a macro level understanding of whether, for example, wear mask or not will increase the contact rate is a very challenging modeling problem, which from the machine learning perspective, I think is totally doable. But in terms of the projection performance, it may not give you a better projection performance than our current modeling. Because we did try several things when we came up with this model, for example, with more parameters or with more sophisticated modeling. But it turns out that the projection result by our current model is more reliable than the projection result of other models we tried during the development process. But I do appreciate that you point out this issue because the contact rate in our model is constant, it's not time varying. This could be something that can be improved if we have a good way to make it a time varying parameter. Yeah. But currently we didn't do that because we don't know how to do that to get a better performance.
Thank you. Next question is Oni from Oni. I haven't seen whether this model could be implemented outside the US, except SIR and SEIR.
Mm-hmm.
If it is possible, are there some other external factors could be affecting the model?
That's a great question. So in this talk, I only talk about the forecast in the United States in different states. But if you go to our website, actually we provide the modeling and the forecast for other countries as well. This include many countries in Europe, in South American, in African, in the I think in the Middle East. So we provide the forecast for more than 20 countries beside the United States. So our modeling techniques is actually very general and generic, because as you can see, the training data of our model is just the daily reported confirmed cases and daily reported deaths. And this information can be found on some website like the World Meter website. They do provide the data for other countries. And actually, we exactly build the model for other countries based on the data from World Meter. And it turns out that the projection is also very reliable. But of course, we didn't pay as much effort as we made for the United States forecast, because this is our current focus. So that means for United States, after we train the model, actually we spend a lot of time just observing or examining the projection, the curve. And there's some like a human intervention during the machine learning process to make sure the model we select is the most reliable or most accurate model for future projection. But for the other countries, the majority of the modeling part is automated. It's just based on automated machine learning pipeline. Based on this pipeline, we didn't do a lot of intervention when we build model for other countries. But in the United States, actually, we spend quite a lot of time on top of the machine learning pipeline. Actually, we spend a lot of time to examine the forecast, whether it's reasonable or not. If it's not reasonable, then we may dig into the machine learning or even the optimization process to understand what happened and how to prevent any, for example, unusual or some like corner cases, to make sure our model is very reliable. Yeah, but in terms of modeling, actually, we do have the modeling for other countries.
Yeah. Next question is from Royal. Is it possible to estimate an age and sex dependent R0? R0 based on dependent on age and sex.
That's a very, I think that's a good question, but it's a very challenging task to estimate the R0 for depending on, for example, age and sex. So the reason is like this. Okay, so if you look at our estimation of R0, right? Actually, it's essentially based on the parameters of our model. And in order to estimate the parameters of our model, we need to use the data, daily reported confirmed cases and the daily reported deaths, right? And within the susceptible group, let's say the individuals in the S group, the susceptible group, there are, for example, people with different, at different, for example, age, and also have different genders or other demographic informations. So in that case, it's very difficult to, for example, separate the individuals because we don't have the information. For example, there are that just give you an example. There are suppose 1,000 newly reported cases in California, right? And you don't know how, you probably can get the information about the age group or the sex, maybe in a few days or a few weeks. But as of today, you probably don't have the information for that. Then we won't be able to partition this group into many subgroups and do the modeling separately. So that's the key challenge why I think it's very difficult to estimate the age and gender dependent are not. Yeah, but if we can do that, we'll definitely give it a try. But I don't have a very concrete idea to do that yet. Yeah.
And this next question is from multiple people. Can the slides be made available?
Oh, yes. The slides actually will be shared with TV, and you can put it on.
Yes, I will do that.
The website. Yeah.
Next question for estimation of prevalence. Have you done the estimation with lower sampling rate or any attempt towards finding an optimal ratio for testing, since 100% test sample size is practically impossible?
Yeah, that's a good question. Actually, because our preference estimation is not based on antibody tests, right? Our preference estimation is just based on the model, our own models. And you can see that the sampling rate when you do, for example, antibody test, actually is very similar to the parameter we introduced here. Okay, so I'm introduced this parameter, which is called a fraction of population that is susceptible to be affected, which is the delta parameter. And this delta parameter, you can understand it as the, for example, the fraction of population that will be potentially tested, because this data determines the initial S0, E0, I0, R0. And during the entire training process, the summation of ST, ET, IT, RT will equal to the summation of S0, E0, I0, and R0. Okay, so because of that, if at the beginning we choose, for example, delta, that means we only assume we are doing a subsampling of the entire population, and the subsampling rate is more or less similar to this delta parameter. Okay, so we do have this kind of sampling mechanism when we do the preference estimation. But you know, this is not the same as the subsampling, the real subsampling strategy people are doing when they do the antibody test.
Thank you. Next question is, can this model be improved to estimate and predict a following status condition once the quarantine status revoked?
Okay, so can you see that question again?
Can this model be improved to estimate and predict a following status condition once the quarantine status revoked?
Oh, yes, yes, yeah. So we are able to model the impact of reopening or the, for example, or shutdown, right? So because this is just like input signal in our model, which I show you on this slide. So this is like alpha t. So alpha t is like a control input. So when you, for example, lift the, for example, social distancing or stay-at-home order, then there will be more people flowing into the susceptible group. And when you impose or when you implement a very strict, for example, stay-at-home order, then actually you can even choose alpha t as like a negative number or something like that. So we can definitely model the impact of the, for example, revoked quarantine or stay-at-home order.
Okay, thank you. Next question is from Prakashan. He is giving the some data about New Jersey, New York, Connecticut, Massachusetts, and Rhode Island. And he's asking what is the reason for high death percentage in New Jersey.
Oh, okay. High death percent in New Jersey, right?
Yes.
Yeah. That's a very good question. Actually, I do have the answer. If you look at R naught, right? If you look at R naught,
Yes.
the basic reproduction number R naught in New Jersey actually is the highest among these about 10 states, right? So that means at the beginning of this outbreak, actually, the situation in New Jersey state is really, really bad compared with other states. In California, the R naught is a 2.2. It's not that bad, right? I think we are doing a very good job in terms of containing and mitigating the risk of the COVID-19 outbreak. But in New Jersey, I don't know what's the reason behind this very big reproduction number. But to answer the question why the death rate is really high, because the basic reproduction number is very high. That means at the beginning of the outbreak, there are a lot of people get affected by this disease. And due to the, for example, the limited, for example, medical resources, or due to the, for example, fact that at the beginning of this outbreak, for example, medical workers or the doctors, they probably haven't come up with a very effective treatment, right, to cure this disease. So it's possible that during that time, a lot of people died in the New Jersey state. I think you can probably also plot the number of daily deaths in New Jersey. I believe now it's declined a lot, but maybe at the beginning, that number is pretty high. And that is exactly caused by the high basic reproduction number. Yeah.
And the next, there are many more questions. You want to go ahead?
Yeah, if people are interested,
okay,
I can definitely, yeah.
So from Rose, are you modeling a relationship of the hotspots with the incidence of at assisted living or nursing homes?
Yeah, so, right. Currently, we haven't done that kind of modeling because we haven't really actively collecting that kind of data. So the data we are using is the mobility data when we do the hotspot detection in Los Angeles counties. And in order to, for example, study the relationship between the hotspot and the, for example, the nursing home or the city living home, we need to, for example, collect the GPS location of those nursing homes. And with that, we may be able to do that. Yeah, but we haven't done that before. Yeah.
From Roberto, without relaxing social isolation, when will we reach herd immunity?
That's a good question. This is related to the prevalence. Okay. So what is a herd immunity? So when the prevalence reach to the 2/3, which is about like a 67%. If the prevalence is like a 67%, then we basically consider it is a herd immunity. But currently you can see that not only in New York City, but also in New York State or other states, the prevalence actually is still much, much lower than 67%. So I don't think we will reach herd immunity soon. And I hope we are not going to reach herd immunity because of course, if we reach herd immunity, then actually this pandemic is somehow is you can consider it's gone. But in order to reach herd immunity, actually, there will be more patients and more deaths. So we have to sacrifice a lot of humans' lives to reach the herd immunity. if the fatality rate does not change significantly between now and then actually we need to sacrifice a lot of human lives. So this, of course, this is debatable because some other countries they think is a good strategy, but I personally don't think it's a good strategy. But you can see the prevalence is much lower than 6-7%. So none of the states in the United States reach the herd immunity, and I don't know when it will reach, because according to our estimate, I don't think any of these states will have prevalence like 6-7% within the next 6 months. I don't think it will reach to that point.
The next question is from Xiaojing.
Mm-hmm.
How much does the estimated peak date move or is sensitive as the new input data comes in the recent weeks?
Yeah, that's a good question. So if we do the peak date estimation, for example, a month ago, then, or first is, for example, 3 weeks ago, I think at that time, it's still quite sensitive. But currently we found that, for example, if I'm using the data a week ago, first is using the data up to, for example, today, the estimated peak date actually is very, very reliable. Because currently, if you look at the RT, the effective reproduction number, actually most of the, in most of the states, the RT is already below 1. So that means we are in this time period rather than this time period. Okay, so when RT actually is less than 1, the peak date, which is the number of active cases, the highest number of daily active cases, will be more or less stable, even if you perturb the model parameter or whatever a little bit. It won't change the number of active cases too much. Okay, but maybe 2 weeks ago or 3 weeks ago, the estimate of peak data is still not that stable. But now I think it's more or less very stable.
Next question is from Ed Sakabu. And the fact that this model works assumes that reinfection is not possible. Mm-hmm. So does this model prove mathematically that reinfection is not possible?
Yeah, so this is the assumption we made. We assume that there's a good amount of time immunity. If, for example, a person got affected by COVID-19 and then recovered, we assume that maybe in the next a year or so, he or she will not get affected again. So that's why once the individual moves into the removed group, they won't move back into the susceptible group. Okay, but there do exist some epidemic models. They actually, we don't assume this kind of immunity. So in other words, there's still a link from the removed group to the susceptible group. And we can, of course, add that link. And that will change our model a little bit, but I don't think it will introduce any additional challenge in terms of model training. But we didn't do that because according to currently reported cases or those reported by WHO, I think the immunity actually is long enough. It's not like only have 3 weeks immunity. I think the immunity is definitely more than several months or even a year. So that's why we didn't. That's why we assume there's an immunity. So we didn't add a link from the removed group to the susceptible group. Yeah.
And next question is from Chiang. What is the assumption or logic for not explicitly adding the unreported number U_t as a system variable in the differential equations in your model?
That's a very good question. Yeah, we didn't add, for example, UT there because the UT actually is just equal to, we didn't calculate the UT, but if you want to calculate the UT, you can still calculate that because you have ET and you have 1 minus mu times sigma, this kind of a transmission rate from E to U. So you can calculate that. But the reason we didn't calculate that is because if you look at our training loss, the training loss basically measures the difference between the reported confirmed cases and reported deaths. Because the unreported number is unknown, it's unobserved, it's like a hidden variable. After we train the model, we do have the number for that hidden variable. But when we define the loss function, we didn't explicitly add it into the loss function. Yeah.
Next question is from Roberto. Asian countries did very well so far using different strategies. For example, South Korea and Japan. Do you know why all Asian countries did so well?
Yeah, I think this is the reason could be, for example, they are doing, for example, more strict like social distancing. For example, they are doing more like aggressive, for example, contact tracing. For example, if someone got diagnosed, for example, in a apartment building, maybe they will isolate the people in the entire building. That's very aggressive kind of isolation, right? I guess that's one of the reasons they somehow controlled the disease or COVID-19 very well. But this is also debatable, because if you are doing very, very aggressive, like a contact tracing and isolation, it will affect your like normal daily life a lot, right? And so far, I think people are still happy about not, at least not very unhappy, because I think we are doing like volunteer, stay at home. And if you want to go, for example, grocery shopping, or if you want to go hiking or doing some exercise, you are still allowed to go. And this makes us don't feel very different from our traditional previous normal life. If we are doing very aggressive, very strict isolation or quarantine, then that will make our life change a lot. So I think there's a trade-off. Yeah.
I think this is the last question, and it's a kind of suggestion for the future work too. Will you do future work on the distribution of vaccines of COVID-19 to help model what are the best options of distributing the vaccine to save lives? This is from Mindy.
Yeah, that's a very good stretching. So I'm not expert on vaccines, but yes, the distribution of the vaccines, I think, is another important question. If we can, for example, produce a lot of vaccines, right, within the next, currently we don't have any like successful or approved vaccines to use. But even if we, at some time we got vaccine, we still, there's still like a production process. And before we can have enough vaccines to give everyone, then of course, how to distribute the vaccine is a very important problem, actually a social problem. I'm not sure whether our model can help, but of course, the high level idea or the principle is if a region, for example, there's a, because there are different age group, right? We probably need to consider that. And also different regions are hit by COVID-19 differently. We maybe also need to consider that factors. But I think this is very complicated like decision-making problems. And I hope our model can provide some kind of guidance, but of course, because I'm not expert on like a vaccine distribution, so we will see. Yeah, if I need to do that, then I'm more happy to think about that. But that's a very good strategy. Yeah.
So I think that's the end of the question. If anyone online want to ask any question, feel free to unmute yourself and ask.
So I just wanted to make a comment because I had asked the question, the last question. I wanted to see if you can at least make some efforts, because I know this is a big problem that we're facing. And I know modeling, of course, of the disease is most important, I think, right now, but a future problem we could have that could potentially make more social problems for the next, you know, century, I would guess, almost. But, I would think make more of an impact as well.
Yeah. I think that's a very, very good point. I think so in the short term, it's more like some like economic problems or right. But in the long term, I think there are a lot more like social problems or consequences we need to figure out and resolve. So I hope I will definitely think about whether our model can provide some kind of advice or guidance regarding to, for example, the distribution of vaccines or other things people are worried or people are more concerned. We will definitely try our best to start to think about that problem. We haven't get to that point. We haven't need to decide it right now, but I think it's always good to start to think about this problem ahead of time. Thank you for your suggestion.
Thank you.
I ask one more thing, one question?
Mm-hmm.
Yeah. So have you done a sensitivity analysis to see which of the parameters of your model are most and least sensitive?
Yes. So yeah, we didn't do sensitivity analysis so far. We are doing something slightly different. Actually, we are doing a very careful model selection, because during our training process, we indeed found that when we use different parameters, we may get the same, for example, training loss. But in terms of the prediction performance, it can be very different. So when we do model selection, because why we need to do model selection? Because with different initialization of those 4 model parameters, as well as S0 and E0, we may end up with different models. All of them give us very small training loss, but some of them have very good projection or prediction performance, while the others do not have. And we select those models that gives us better projection performance. And we found that for those models, around that model parameter, if we perturb it a little bit, actually is relatively stable. But for those models which do not have very good prediction performance, the corresponding parameters are indeed very sensitive. But we didn't do a sensitivity analysis in our modeling. And thank you. I think that's a good point. I think we probably should do it, soon to make sure the model, the parameters we selected, or the parameters of our model are not very sensitive, because our model is not a standard epidemic one; it's a modified one. So doing sensitive analysis, I think is a very important.
So when you said that you look at the various models, but isn't this your single model that you're actually using, and it's this set of parameters that are the critical ones for making your predictions?
Okay, so because the optimization problem depends on the random initialization of these 4 parameters: beta, mu, sigma, and gamma, and also depend on the initial S0 and E0. Because in our training, we set S0 plus E0 equal to delta times N, and we set I0, R0 equal to 0. So there are in total 5 parameters we need to initialize. And by using different initialization, we may end up different models. And some of models, they have very small training loss, but they have very bad prediction performance. While the other models, they have both small training loss and good prediction performance.
Okay, so, so the structure of your model is the same, but the parameter space has different regions, and that's what you're classifying as different models.
Yes, yes, exactly. The structure, the architecture of the model is the same, but the different parameters may give you similar training loss, but different test performance. Yeah.
Okay, thank you.
Yeah, thank you.
One more question from Priyanka.
Mm-hmm.
What would be the outcome if we simply plugged the data into a regression model to predict the future cases and deaths? Will that work equally well or worse than this model?
Okay, then the question is what kind of regression models can we use? If we are using linear regression, then I would say it probably won't work very well. But if we are doing, for example, polynomial regression, which is powerful enough to fit any like a trend of the data, then I would say the polynomial regression in terms of short-term prediction. For example, based on the data, based on the historical data until today, I want to predict the number of deaths and the confirmed cases tomorrow. I think a polynomial regression will give you relatively good prediction. It's very similar to the IHME model, which is called curve fitting. So they are using something not as powerful as a polynomial regression, because that will cause overfitting, but they are still doing some kind of curve fitting. And their model actually, in terms of short-term prediction, is very accurate. For example, just predict the number of confirmed cases and deaths tomorrow or the day after tomorrow. They may give you very good prediction. But in terms of long-term prediction, like the number of confirmed cases and deaths in a week, in 2 weeks, in a month, or in several months, then polynomial regression won't work. It will basically overfit the historic data too much, so that it won't be able to give you very good projection for in the long term. Yeah. But in the very short term, in a day or in 2 days, I think it still work. Yeah.
I think we don't have any further question at the moment. So, thank you very much, Dr. Gu, and thank you for all the participants who stayed and listened to the very important talk, contributed to the discussion. I will get the slides from Dr. Gu and share with you all. And thanks again, and thanks to our speaker.
Yeah,
thank you.
Thank you. Thank you for hosting me, and thank you for everyone attending my talk. If you have more questions, feel free to send me email. You can easily find my email on my UCLA website. Thank you.
Thank you.